I want to introduce Dr. Jamie Scacia. She is a clinical psychologist with specialization in developmental trauma. She's the director of assessment at Family Forward, an organization that leads those impacted by trauma in the direction of hope. In this role, she manages a team of evaluating professionals along with a small caseload of clients. She also sits on the hub team for the Foster Care Echo in Missouri, and she enjoys presenting at conferences and is the training director for the pre- and postdoctoral psychology internship and residency programs at Family Forward. Dr. Scacia has utilized the frameworks of the neurosequential model of therapeutics along with the therapeutic assessment model to enhance psychological evaluations to be more trauma-informed and client-centered, including client's experience and role of differential diagnosis. She continues to explore the complex nature of overlapping diagnoses, especially that of autism spectrum disorder and complex trauma. So I'm definitely delighted to continue learning from Dr. Scacia, and for the next 45 minutes or so, we're going to listen to her share with us her expertise, and again, that intersection and our ability to think about more than one thing at a time. And so, Dr. Scacia, thank you so much, and I'm turning it over to you.
Thank you so much for having me. I am super excited to be here, and just want to echo a little bit about what Dr. Sowell mentioned, which is my specialization is in trauma, and I feel like such a privileged guest here with the ECHO autism community. But just to remind you, that means that my lens is trauma. And so as much as I try to stay informed, I might mess up with my language here and there. I might see things from a different perspective, but hopefully part of that will contribute to the conversation and dialogue that we have, as opposed to shutting anything down. The other thing that I'd like to mention before I really get into things is that trauma can be really difficult to talk about. So just be mindful of where you are, your own personal response to some of this content. And if you need to excuse yourself for a few minutes, I won't say anything so important that we can't, come back to it later. So keep in mind that, and also that I'll be talking in generalizations because the autism community is so vast, the trauma community is so vast, and then if needed, we can get into more specifics with questions. So we are going to focus on, if I can get things to move, how regulation impacts how we respond to and treat those with autism and those with trauma. So there's a huge overlap in the symptoms of trauma and the symptoms of autism. And so we're going to review some of that and talk about how that impacts things like intervention and our understanding of behavior. Just as a little teaser, adults with autism are about 4 times more likely to be diagnosed with PTSD than those without autism, but kids and teens with autism develop PTSD at a similar or higher rate than peers. So the research really varies on some of these things, and we'll kind of see why as we continue going. This, in addition to differences in both self-regulation patterns and sense-making of experiences and the world, leads to vulnerability to the psychosocial consequences of experiencing adverse events. Let's add on social vulnerability, whether that's dependency on family, family stress, trouble with communication, all adds to those risk factors. So what is trauma? There are 2 different types of trauma, and we'll get into what those specific definitions are. But one type of trauma is simple, what some folks call type 1 trauma. And that's often a person has experienced one big T trauma, and that could be a car accident, that could be a hurricane, and that can absolutely bring on symptoms of PTSD at the time or down the road. My specialty is a little bit more in the complex type 2 trauma, and those are the types of trauma that we experience that really impacts how we see the world pervasively. So it's not just, I had a car accident, now riding in the car really makes me nervous, I'm scared it's going to happen again. Complex trauma integrates into how we see ourselves, how we see the world, how we see relationships with others. So examples of those might be, growing up in a household that includes domestic violence. It might be experiencing chronic and severe poverty. that impacts our access to nutrition, our access to proper clothing. It might be abusive relationships. So you could see how those things would really impact us on a regular and ongoing basis. Developmental trauma changes the brain of the experiencing child. So if we have early developmental trauma, so trauma that happens within the first 3 years of life, those things impact the way our brain develops, the structure of our brain, the connections that our brain makes. And so it's unfair to say, even as an adult, well, but you were so young, or you were just a baby. Those things are coded in our bodies, whether we like it or not. And if it's coded without language, whether that be pre-verbally or the person doesn't have language that they can express outwardly, those things are coded in a different way. So that might be in the way that we interact with our world by our senses. That might be the way we respond to noises. It could be a variety of things, but those memories are still there. They're just coded differently. So do ASD symptoms and PTSD overlap? Take a second. Hopefully, if you're joining me right now, you've thought a little bit about it. And just think about what might be a trauma response and what might be a characteristic of autism. And are there things that would maybe muddy the waters a little bit? Things that would say, well, I don't know which category this would fall in. That's what we're going to get into a little bit. But we'll start with what is PTSD. PTSD has a long history that we're not going to get into, and it's evolved over the years, similar to autism, in fact. But PTSD requires a few different things. It requires re-experiencing symptoms, which can be anything from flashbacks, nightmares, intrusive thoughts, physical distress if we don't have that language to put on it, avoidance. So avoiding any kind of reminder of the traumatic experience. So that could be places, people, feelings, thoughts. I know when I get anxious, I start to connect that to how I used to feel. And so I just do everything I can to keep things organized and planned so I don't have those anxious feelings again. Arousal and reactivity symptoms. So that might be a strong startle response, or sleep, irritability or aggression, risky behavior, trouble focusing. And then finally, cognitive or mood symptoms. So trouble remembering the event, feelings of negativity or self-blame that are more than you would expect, loss of interest, isolation, lack of positive emotions. So hopefully you're starting to see already, wait a minute, that could be a characteristic of autism too. Or, if you don't have the right context, those symptoms might be taken differently. Furthermore, the DSM fails us, and you'll gather my feelings about the DSM as we go, but there's not a complex or developmental trauma diagnosis for us to utilize. So we're really stuck with this PTSD diagnosis if we want to be specific about somebody's trauma response, and that really limits us as well. So how has the definition of trauma changed over time? Originally when they first developed this diagnosis, it was thought to be something that only soldiers experience, something that, when men came back from war, they were different, and this was a way for them to articulate that. But now it's becoming more understood as a subjective experience. So if that person interprets the situation to be traumatic, that has a much greater effect than if we objectively come to the situation and say, that's not, why does that bother you? I experience that all the time. So how does that change with autism? And I feel like we could have a really great discussion if everybody was sitting here in my living room with me. But instead, I'll just tell you. PTSD symptoms can be more easily triggered in those with lower intensity experiences, with people with heightened stress reactivity. So we are more sensitive to what happens around us. Our threshold for tolerating experiences is lower. So things that I might be comfortable with, the person next to me might not be comfortable with. And a variety of things might be included in that. So things like bullying, unexpected sounds, misunderstandings, and life transitions may be included. And those are things that the original definition of trauma did not include. It used to just be things like events in which the person felt their life was in danger. Now, we might not always feel that way when we're going through a major transition in our life, but that doesn't mean that experience wasn't traumatic for us. Interestingly, one of the studies that I reviewed for this presentation reflected upon exclusion and being what they called socially trapped as a possible traumatic experience. And that would include things like institutionalization, disenfranchisement, and really societal's limitations on autistic people's ability to reach goals that are, common to most humans. So things like the drive to excel, to reach your goals, to be autonomous, to connect with others. Those things I think sometimes are removed from the opportunities given to people with autism, and unfairly so, in a way that makes them see the world different, experience themselves different, experience the way they interact with other people differently. And then finally, thinking about things like the incongruities between sensory experiences, executive functioning skills, social processing, those things can make the experiences people have feel differently. So if I have a very strong distaste for certain noises and I go into an environment and I feel like I can't escape that noise, that might be very traumatic for me. And it might bring up a lot of symptoms or feelings in me that are aligned with some of these on the screen. Avoidance, I might strongly avoid that situation. I might feel guilty or shame that I had to leave. But that noise didn't bother anybody else in the room. So again, coming back to this idea that some of these interpretations are very subjective. So what is happening when a person experiences trauma? The first thing that happens is we develop triggers. And I know that word comes with some feelings for a lot of people, but these triggers can be really obvious to us. It might be, okay, I'm not going to go back to this house party because I know they play that kind of music, and, coming back to our previous example. But a lot of times they are unrecognizable either to the person or to the observer. So that might mean, having a parent in your office who says, I don't know, all of a sudden they go to 0 to 60 for no reason. And it's usually not that. Usually there's a reason, we just haven't pinpointed it. And it could be a sensory input. It could be a feeling inside the body. It could be a thought that crosses their mind. It could be seeing somebody who looks like somebody else, and that was enough. So the first thing that happens usually is there's some kind of input that is a trauma reminder. And this leads to dysregulation. When somebody is dysregulated, and we're going to talk a lot about this, the ability to think clearly decreases. So the ability to access complex thinking skills. So those are things like focus and concentration, planning, being able to think about the future. Our ability to do those things decreases. So coping skills, access to coping skills is a complex thought. Okay, I need to stop what I'm doing now. I need to go over here where, some of my supplies are for my coping skills. I need to sit down because I'm upset. If we're dysregulated enough, all that goes out the window. The emotional and reactive responding increases when somebody is dysregulated. And hyper or hypo arousal is often a response to those situations. So let me give you an example. Let's talk about just basic conflict resolution. If I'm regulated and somebody shoots me an email that says, you were supposed to have turned this in yesterday, why didn't you turn it in? We really need it to be able to move forward on this project. If I'm feeling good that day, I might say, oh my goodness, I can't believe I forgot it. Let me put aside what I'm doing right now. How can I meet your needs? Let's talk about this. Let's find some kind of middle ground. How are you feeling? I'm so sorry I let you down. But if I'm not in a good place, my first thought may be, how dare they? They knew how busy I was. And this is awfully disrespectful for them to include all these other people on the email. Now they know. And I start going down a rabbit hole. And maybe my email response, I need to press pause and I need to wait a few hours before I press the send button. So even in that one situation, that's not a trauma response necessarily, but you can see how dysregulation can impact the ability a person has in that moment to respond in the way that they feel like they are doing their best responding. So how we respond to people in our environment, whether that's a person with autism or not, we need to consider what state they're in. Are they in a regulated state or are they in a dysregulated state? Oftentimes I get parents who come in, let's say it's a 15-year-old person who identifies as male, and they say, when he is at school, he's like a normal 15-year-old, and he goes to classes and he has friends and everything's fine. But then when he comes home, it's like he's 5 years old. He doesn't do what I'm asking, he'll throw a fit. And then when it comes to when he's with his friends, it feels like he's 10. So we need to think about where the person is developmentally in these different scenarios and respond to them as such. If the person is acting like they're 5, it might be because they're so dysregulated that those are the kinds of skills that they have access to in that moment. And we should respond as such. We should be respectful of that. It also goes to show that that our development isn't linear. And I know we've talked about that a little bit already today, but our educational development versus our social development versus our emotional development versus our cognitive development, all of these things don't happen at the same rate. And so, we also should be mindful of, varying differences. We can't say you look like a 15-year-old, so I'm going to expect 15-year-old behavior across the board. It's just not true for anybody. So while we're talking a lot about autism today, all these things that we're talking about in this presentation is true across the board, no matter who you are. Relationships act as a buffer to stressful events. So two people may experience the same event. One may end up with symptoms of PTSD and another might not. And a lot of times that comes back to what kind of resiliency factors are at play and what kind of support did that person have during and after those events to help moderate those symptoms. So this is a visual to talk a little bit about what we've been exploring so far. All humans get dysregulated when they feel threatened. However, the word threat is very subjective. Like we talked about, trauma can be subjective. What things are triggers to our reactions can be subjective. But these things put us into fight or flight. So here's a picture of the window of tolerance. When we are within our window of tolerance, we can act as our best selves. We can act in a way that we would reflect upon and say, yeah, I used the best skills that I had. I did my best. I worked as hard as I could. That feels like me. But when we are dysregulated, we generally fall either into the hyperarousal zone or the hypoarousal zone. So if we're hyperaroused, this is those kids who maybe seem really anxious or easily irritated, angry. And a lot of things go in with that. When our body is revved up so much, we are probably having a hard time sleeping. Probably our heart rate is higher. Probably have some kind of racing thoughts or digestion issues. A lot of these things can go hand in hand. On the flip side, if we get hypo-aroused, this is more of what we think of people who tend to dissociate. So they may feel disconnected from their experience. They may be overly compliant. So they might just do whatever is asked of them just to get through the situation. They might seem withdrawn, depressed, and attentive. So already, I'm sure you can start to see how if we are outside of our window of tolerance, a lot of these behaviors can look like a lot of things. Some can be autism related, some can be ADHD related, some can be depression or anxiety. That as soon as we're outside of our window of tolerance, our access to the things that help us stay within our best selves reduces. And novel situations, so encountering things for the first time, can bring about some level of dysregulation for all of us. So those with trauma may even wake up in the morning. They may start their day every day already dysregulated. So, whereas I'm waking up and I might look at my phone, I might check the weather. Somebody who's dysregulated already might have some of these anxious feelings or depressive feelings, making it easier for them to get more and more dysregulated throughout the day. The other side of that cookie is that soothing is subjective, just as threat is subjective, soothing is as well. So what is relaxing and comforting to me is going to be different than what is relaxing and comforting to somebody else. So I might go and try to hug somebody who's having a really hard time, and that might be the last thing that that person wants. In fact, that might send them into a greater state of dysregulation. So being really mindful and thoughtful about that person's experience, their history, their current presentation of behaviors, all those things are really important to take into account when we understand why behavior is happening and also how to respond to it. So there's actually a lot of reasons why those with autism might be more vulnerable to trauma. And I'm sure you can guess a bunch of them. And I'll just go through a few of them, and we can always come back to this if we feel like we need to. Sociocognitive features of autism. This might include things like trouble with mental flexibility, differences in processing and perception of experiences, reduced goal directedness, or trouble with utilizing coping skills that effectively help work through situations as opposed to calm the nerves in that very moment. Processing differences in autism may lead to differing perceptions, and those things can impact things like confusion and powerlessness, difficulty with understanding social subtext of a situation, or missing the context of an event can impact what they believe to be traumatic or what they feel is traumatic. This has also been shown to contribute to things like confusion, powerlessness, utilization of coping skills. And then we add in things like sensory differences. How we make sense of a situation is entirely based on how we experience that event, and therefore how we cope with it. There's also been some research to show that there's an overlap in the brain mechanisms between autism and PTSD. So things like how our amygdala and prefrontal cortex function, the HPA axis, the hippocampus, those are all really overlapping things that are happening in the brain, and makes sense then that we're seeing similar behaviors as a result. That's to say, just because somebody has a different perception of an event or what is traumatic doesn't make it inaccurate. So coming back to the point that trauma is subjective, we cannot come to somebody and say, those loud noises were just loud noises. That party that you went to and you didn't feel like you can leave, you should have just sat down and put your headphones on, or you should have just taken a walk outside. It is not up to us, and it is not up to that person either, what our brain interprets as traumatic and therefore has traumatic responses to. Additionally, autism can influence how trauma is processed, and likewise, trauma can impact how features of autism are displayed. And these are unique responses. We cannot expect somebody with a trauma response to be a certain way, just like we can't expect somebody with autism to behave in a certain way because they have autism. So again, we're seeing a lot of overlap in the communities of those with autism and those with trauma, in the same ways that both communities are coming to the table saying, society is putting expectations on you that it doesn't always need to. You know, somebody used the example earlier that I love about her daughter sitting under the table during dinner. And at some point, we have to say, okay, like then she sits under the table during dinner. And in other scenarios, that might have become a major problem because it's not what we expect based on the rules of our society. It's different, and that makes people uncomfortable. But both the autism and trauma communities are coming to the table saying, you can be uncomfortable, but that's what I need to do in this moment, and that's okay. Okay, overwhelming slide, I get it, but let me tell you what we want to pay attention to here. This is a model that highlights the role of trauma and autism together. And you can see, at least by all these different arrows on the screen, that a lot is happening. So what I want to highlight for you are just a few things. One is that autism can impact what is potentially traumatic in the first place, what is perceived to be traumatic. Autism can impact what events are perceived to be harmful or threatening. Autism can impact the risk of developing symptoms as a result of those encounters. Autism impacts how trauma symptoms manifest. And in turn, these experiences may impact the presentation of autism characteristics and overall development. We can't separate one or the other. And doing so gives us an artificial sense that we are doing the proper intervention. If we try to separate them, we are not addressing the full person, and that's a major risk. So unfortunately, even though we really want to be able to say, and people come to me with this question, you know, every day, is it autism or is it trauma? There's just not an answer to that. A lot of times we don't know enough about the early behaviors of a person to be able to recognize, developmental regression or early signs that we might have some autism traits. And if a person is exposed to trauma in utero or right when they're born, we don't know what behavior would have been like without it. So the overlap is really important to pay attention to because it exists and it's I want to say unmovable. You know, there's not an intervention that we can do that's going to say, okay, now we know these are autism behaviors and these are trauma. I know, I just showed the slide, but I really had a hard time deciding where the slide should go. I wanted it here, I wanted it at the other place too. So eventually I just decided to put it both places. And the reason I'm showing it again is because this is the main point that I want you to take away today, is that when dysregulated, if we are over aroused or under aroused, we are not functioning at our best, which means I might be able to interact with you in one way, in one scenario, and another day in another scenario, my interaction with you might look very different. My behavior in the classroom might look very different on Tuesday as opposed to Friday. My behavior might look different if I'm in the classroom versus when I'm at home. So I just wanted to kind of have this reminder as we go into the next slide. It's just a chart. I know there's a lot of words, but what we do know is that the overlap has nothing to do, whoopsie, my apologies. Behaviorally defined symptoms do not give us insight into the cause of those symptoms. So here I'm highlighting how difficulty with social skills falls in both categories of autism and trauma. And neither one gives us an understanding of why a person is having trouble with social skills. So relationships can be challenging regardless of the diagnosis. For folks who've experienced relational trauma, relationships have proven to be unsafe in the past. So social skills rooted in relational connection, getting close to somebody beyond that superficial interaction, can be really challenging. In fact, people who have complex or developmental trauma tend to be really sensitive to nonverbal communication and respond to that before given the chance to explore that information cognitively. So again, the information gets interpreted before we are able to process it with those more complex thinking skills. And I liken it to touching a hot stove. So if we touch a hot stove, we are not allowing our brain to utilize that information long enough to be able to sit and use our complex thinking skills. We're not thinking, okay, if I leave my hand on here, I'm going to get injured, and then I'm going to have to go probably to the hospital to get treated. Then I'll have to miss work, and I can't afford to do that. We're not doing any of that. We're just moving our hand away. Our body is responding before we're even thinking about it. And so sometimes social skills for people with complex trauma can be very similar. They see a certain look on somebody's face, or they hear a certain tone in somebody's voice, and they were responding. Their body is responding. They're having feelings, or they are having automatic thoughts that are not using those complex parts of the brain. They are more automatic, they are more reactive, and they are more emotional in nature. So you can see then how some of those patterns of responding can be similar to those with autism. And so if somebody comes into the office having trouble with social skills, that does not give me enough information by far to be able to understand what I'm looking at. We also know that restricted and repetitive behaviors can serve to be anxiety reducing. For those who've experienced trauma, life has been unpredictably dangerous, and increasing the amount of predictability in their environment can help to reduce anxiety as well. So things like disconnecting to their lived experience in that moment, having what we might think of as odd or eccentric practices or rituals that they do, that could be related to anxiety, that could be related to autism, that can be related to traumatic responses to, I need to feel some sense of control in my life, and so I'm going to maintain this ritual because it's something I'm comfortable with. I can predict it and I can control it. Furthermore, following exposure to trauma, kids may exhibit concentration difficulties, regression in their daily skills, so their hygiene might decrease, their ability to follow through, their concentration might decrease, an increase in the levels of repetitive behavior. Again, you're seeing this overlap happening. So can PTSD and autism exist together? Of course. Consider how dual diagnosis might impact the presentation of behaviors and symptoms. So we can talk a lot about what autism is and what trauma is, but when we're talking about both together, we're talking about yet a third thing. So how do we do that? How do we start to understand which is which, what is what, and how those things come together? I'm just going to talk about this briefly because I know not everybody here is an evaluating psychologist, but doing things like clinical interviews has to go beyond the child and the caregiver in the room. It has to include teachers, doctors, babysitters, whoever the family feels are important people in the child's life. So that might mean a grandparent, that might mean a neighbor, but having some faith in our families that they are experts on what's happening, and so they can refer to whomever might have some input. Is there observing the person in different environments? So again, we can talk about these symptoms a lot, but if we don't see some of those things, we might not be able to have all that information. And furthermore, symptoms change, characteristics, behaviors change, depending on the sensory input of the room, depending on the social dynamics, depending on if mom or dad are there or not, depending on if I've been here before and something bad happened. So being able to see them in different environments can give us a lot of information. Considering the limitations of our testing materials, I do evaluations for a living, so I have a lot of positive feelings about testing materials, but this is an environment, this is a specific niche that is near impossible to provide testing materials that's going to meet the needs of every aspect of that person. And that is a huge limitation we have in our field, and something that anybody who's doing assessments needs to remember, that I am not familiar personally of measures that are normed on both autism and trauma together. Some are very specific for autism, some are very specific for trauma, and we don't get a lot of that overlap, much less things like cultural differences, racial differences, educational differences. And we do know that some with autism respond to questions on items in a more literal manner, or struggle with emotional awareness, and that's going to impact their responding as well. It's also important to collaborate with other professionals, knowing our own limitations. And I think somebody mentioned this morning, part of an assessment might happen with a speech therapist, part might happen with a neurologist, part might happen with a psychologist. So being able to collaborate and all come to the table with our own perspectives is crucial for the family. And keep in mind too, that some of our testing measures aren't going to highlight what may be perceived as traumatic, because the general population might not always perceive it that way. So what to remember when considering differential diagnosis? First and foremost, understanding the person for who the person is, their behaviors within the context of their own experience, their own history, their own culture, their own intersectionality of identities has to be understood before we're even thinking about diagnosis. And I think it's a big flaw that a lot of clinicians have, is we're going in really diagnosis heavy. And first we need to understand that person. And our diagnostic system is flawed anyway. We don't have the opportunities for complex trauma diagnoses. We don't have the opportunity to highlight the complexity of the person outside of a categorical label. And in some ways we need that. In some ways, especially in the place that our society is right now, we can't do without it. But we as clinicians need to know the limitations of that. Because each one of us, I was going to say the people we work with, but the reality is each one of us is very complex. And the more complexity that we're bringing to the picture, the less we're going to be able to take a simple response. And again, that is a function of our society, that we want to be able to get an answer. We want to be able to take a pill. We want to be able to have the solution that's going to fix something. And the complexity of our human nature doesn't allow for that. Consider your lens. If we are only having an autism lens, and absolutely for myself, if I'm only having a trauma lens, everything starts to look like trauma. Everything starts to look like autism. An example would be people with autism traits may have poorly differentiated emotional responses. They may be harder to soothe once aroused. They may have trouble regulating negative affect. That's true for trauma too. So if I'm looking at that from a trauma perspective, I might be like, great, I understand what's happening here. But taking a step back and remembering the bubble that we live in. Diagnostic overshadowing is when somebody comes in maybe to the office with an autism diagnosis already, and therefore all the behaviors that the person is displaying is interpreted as autism behaviors, and we're forgetting that there could be other possibilities going on. We're forgetting to even evaluate for trauma. We're forgetting to consider that ADHD might be influencing those behaviors. So diagnostic overshadowing can be a challenge for us to keep in mind as well. And then finally, research is flawed. The lack of inclusion of people with autism in trauma studies and vice versa makes our research really limited. So I have about 5 more minutes, and I really want to be mindful of time, knowing that I'm not going to get through everything that I brought today. But I do want to focus a little bit on how does this impact treatment. So knowing all of these things, first of all, always taking a trauma-informed approach, putting the person first, and centering our responses based on that individual's makeup is going to be important across the board. Doesn't matter if that person has experienced trauma or not, but that taking that approach is really going to help the person feel seen and validated. Regulate, relate, reason is a phrase, I think, coined by Dr. Bruce Perry that really reflects that if somebody is struggling in that moment, the first thing we need to do is help them regulate. Because if they are not in that window of tolerance, they're not going to be able to use their brain to its fullest extent. So the very first thing we want to do is get them back into that regulated state. Then we reconnect with them. We see them, we validate them. And it's only after those two things that, if needed, we reason through the situation. We provide consequences or responses, but we can't do any of that. None of that's going to register because that's all complex thinking parts of our brain. So we have to work in this order for things to register. Relationships are protective, keeping in mind that relationships as deemed protective by that individual are deemed valuable to that individual. And then keeping in mind the role of language and memory. Their language may be more difficult to utilize when we're looking at more traditional trauma-focused therapies, and that we might need to be creative in the way that we approach intervention. Resiliency factors, so things like what does success look like for that individual, not defining it for them, being able to find confidence in neurodiversity, that just because society works this way doesn't mean I'm wrong or bad for working that way. Social support, general health, and getting support for those in the network. So caregivers, support staff, things like that, they also need the opportunities to regulate. And so making sure that that is not lost. I think I'll end with this slide. So what we don't know, research is flawed. So we don't know a lot. It makes treatment much more complex when treatments are validated on one population or another, or the inclusion criteria to be included in a research study is you have to have an IQ of this amount before you can participate, or you can't be physically aggressive, or you can't participate. It really narrows down what we're looking at in terms of our options and the effectiveness of different treatments. We can't simplify complex presentations, as we talked about. And what's not really included in the research is how trauma may be understood with those who have traits that are more impairing, whether that's a lower IQ, whether that's less verbal skills. We don't have a great grasp of interventions with that population in particular when they've experienced trauma. In fact, the research really even struggles to say, how do I identify that there has been exposure to traumatic events when that person doesn't have the verbal language to tell us? Our world is so verbal that it makes assessment and evaluations that much harder. The limitations of the DSM leave us forced to categorize clients for funding purposes, and also the danger of overgeneralizing behaviors, minimizing other behaviors so people fit into the categories neat and tidy. And we know, I don't have to preach to the choir, that can cause a lot of problems. And our fields have a lot to catch up to. So I do have a couple other slides just in terms of being more trauma informed. So I'm going to encourage you to look at SAMHSA's website, and there's 6 principles of trauma-informed care, because, honestly, it doesn't matter if you work with a typically traumatized population. These are really important things that we need to be incorporating into our practice anyway. And it's just a good opportunity for us to reflect upon, are we doing the best that we can in all these different areas? So I think I will call it quits there.
That was awesome, Jamie. Thank you so much. I really appreciate the time that you took and helping us to better understand trauma and that overlap. And so I want to take the opportunity to ask you some of the questions that came in the chat. And so one of them is a question about kind of asking about trauma when it comes from a clinician standpoint. So the person asks, I have no problem asking my patients about identity, sexual orientation, suicidality, homicidal ideation, but I don't really know how to ask about trauma. What are some of the ways to do it?
Excellent question. And I think it's important to recognize that, we talked a minute ago about how those with trauma can be much more sensitive to nonverbal interactions with other people. And so if somebody is tiptoeing around the idea of trauma, or they recognize the discomfort somebody is bringing to the table, those things are going to be, filed away, and they might not feel like you're a safe person to talk to. You were so uncomfortable asking me that question. I am absolutely not going to tell you all about this. So I think developing some comfort is really sometimes more important than the question itself, because you can trip over your words, but if you are genuine and really interested in what that person has to say, that can bring a lot of value to the table. But to answer the question more directly, some folks are more interested in writing things down. They're more comfortable with like a survey, and some folks are more comfortable speaking about it out loud. Some people don't want the caregiver in the room. Some people might say, I don't know what domestic violence is, so no. So really being attuned to the population that you work with, being attuned to some of the warning signs, maybe that that person's feeling uncomfortable in this moment, or maybe I should excuse the caregiver for a few minutes so we can talk about something a little bit more personal. So picking up on the cues about what's happening in the room, and then just being honest. These are really important things, and my main goal is to keep you safe and to make sure you have what you need to be your best self. And then the rest will come from that.
Love it. Thank you. That's super helpful. So a different topic altogether, but still one related to trauma. So the question is coming about, could you please discuss trauma caused by living in a world that doesn't support autism? So the next statement is unpredictably dangerous describes every day as an autistic.
And that's where we start to move into this idea of complex trauma. It has impacted who you see yourself as, how you interact, how the safety in which you experience interacting in relationships with others, your sense of comfort going out of your house and into the world that is unpredictable. And I think there's honestly an argument in the same way that we would discuss things like systemic racism and microaggressions being traumatic. I think we can apply that to this community as well, to say those things are real, they add up, and they absolutely impact us. And so just because our, like I said, you would gain how I feel about the DSM by the time this was over. Just because our DSM isn't going to really get into, if you have autism and you have, these experiences, maybe PTSD, it's just never going to do that. But we as clinicians can understand that those experiences are by nature traumatic. And how do we be sensitive to that and address it in that way, through that lens?
Appreciate that. I think that's really helpful. A set of questions comes around the idea of thinking through. Some professionals in psychology in particular is the basis of the question, but I've definitely seen it in other places too, will say, I don't want to evaluate for autism, and I said this a little bit in the prelude to the discussion, until the trauma is treated in order to avoid a potential misdiagnosis of autism. Assuming trauma occurred after age 3 and or the kid was old enough to have verbal processing of the trauma, so in other words, like assuming that is the context with which the trauma occurred, they're feeling like they should treat the trauma before addressing whether autism is or isn't on the table, so to speak. And so I know you talked a little bit about that, but can you speak to that a little bit? And I'll add this last piece to it too. Similar question by a different, or by a participant, was about ADHD, kind of same thing. Like, well, maybe I shouldn't evaluate ADHD or diagnose that until the trauma is diagnosed, things like that, or trauma is treated.
Yeah, and again, this is where our diagnostic system kind of fails us because
Yeah.
we can't really be guided so much by these labels in a way that's going to restrict everything that we're doing. And I'm going to reference one of my colleagues, Kristen, who I'm pretty sure is on this call, but when she started working on my team, we were not doing autism evaluations. And she said, but if we're not doing them as trauma experts and psychologists who do evaluations and diagnoses, who is? And so if we start to silo ourselves so much, and she's exactly right, if we start to silo ourselves so much, then the autism expert and the trauma expert are never going to encounter one another, and that person's never going to get any kind of integrated treatment. So if we're looking at something like a type 1 trauma, a simple trauma, in which, okay, we can do a few weeks of intervention and probably going to start to reduce those symptoms, then maybe that's an appropriate response. But if we're looking at anything beyond that, especially in terms of complex trauma, it's integrated into who they are in the same way that autism is. And so trying to, piece apart those things is going to be ineffective, and it's going to be ignoring parts of who that person is.
Yeah. And I wholeheartedly agree with that. I mean, I think sometimes there's a phrase I often will use, which is don't let perfect be the enemy of good. And I don't mean, I mean, that's a very broad sweeping statement, but I think sometimes professionals get so insistent on it being the right answer that they almost miss the forest. I never get these sayings quite right, but like, in other words, like you miss the whole point is to help understand what's going on with this kid and or this person or adult or whatever. And so because we've spent hours and hours and hours and hours and hours trying to tease apart, but no, I don't think it's this, I think it's this, you then all of a sudden lose sight of the goal, which was really to better understand what we can do to support this person. At least that's kind of how I see it. What do you think?
Well, and coming to the table again, person first. So
Yeah.
let's understand the person in its entirety, and remembering that our diagnostic system is man-made and therefore has flaws and limitations, and it itself will evolve. That I bring these tables into these to the table. I bring to the table these difficulties, these struggles that we have, and I'm transparent with families.
Yeah.
I'm transparent to say, our DSM sucks, and this is what we have to deal with. But these are the strengths that I'm seeing. These are some differences that I'm seeing. These are some recommendations that I have. This is where I'm putting the diagnostic category right now, and we might see things shift here, or we might see things evolve over here. But you can always come back and chat with me about that, and we can always reflect upon the evolution together. And this is where we are right now. Humans are going to change too.
Yeah, I could not agree more. And I think something that you said that I just really want to highlight for people is this notion of, you put it nicer than I do usually, but like the whole concept of being in a diagnostic bubble. So when you see trauma, like when you're an expert in trauma, that's what you see. When you're an expert in autism, that's what I see. The other way of saying it is when all you have a when all you have is a hammer, everything's a nail, right?
Yeah, for sure. Is it a nail? Because,
Yeah.
that is
Right. And so, and I struggle with that too, which is why I try to keep up on, again, in engaging with others who have expertise in different things so that it doesn't become well, I'm really good at knowing autism, but I'm not as good at, seeing what I don't know how to see. Right. And so I think that's the role of professional development, is to really keep challenging ourselves to learn and to grow. And then, I hope those that are listening and learning with us today hear the really raw truth around the fact that our research is very seriously lacking when it comes to all of these different this word is heavily overused these days, but intersectionalities of all the things, right? All of it. Because frankly, when we look at the autism specific communities between profound and autism, profound autism and autism, that's a really stark lack of research in just within autism, let alone how does trauma influence autism? How does gender and all these different things? And so I think it also comes down to a piece where, obviously researchers and clinicians and people are doing the best they can to try to better understand these things. But I do feel pretty strongly that more people need to accept that they don't know everything, right? That they don't. I mean, this is something that I'm speaking to the professionals on here, but it's like you don't know everything. In case this is a news flash, which I hope that it isn't, but you don't. And so thinking about, well, how can I learn more? And I liked what you just said, Jamie, about revisiting things. I think that's also really, really important. I have a very frank conversation with many families. If I'm on the fence and I just can't decide, or maybe I can, but I'm still really on the fence, I'm very transparent about that. And I'll say, the good news is in my practice, I continually follow people after I've made the diagnosis or what have you. But I also have a very firm saying that once a patient, always a patient, which is somewhat of it's not actually a joke, it's a legitimate thing. But that's because people evolve, right? And I also know that I'm not always going to get it right. And so that's because I'm honestly not trying to be perfect. I'm trying to do the best I can with the information that I have. And I really think that is so profoundly true in in this space between autism and trauma, or really the overlap between autism and trauma. So thank you